join later. But they can always watch it later. So if you want to introduce yourself and then talk a little bit, and then Emmy and Samantha, if you have questions, you could put it in the chat or just ask directly. And then as people join, we can have you field those questions too.
Okay, great. I'm Pilar Haynes. I was a student at Mount Sinai. I did almost 100% of my training at Sinai. So I stayed on to do residency and fellowship. I left very briefly for private practice, and then now I'm back, kind of, sort of. I'm at Mount Sinai, South Nassau, and Long Island. I'm a cardiologist, a non-invasive cardiologist there, in charge of the echo lab. And so for me, I was born and raised on Long Island, and I went to college upstate, but it was very important for me to come back home and train. And, you know, Mount Sinai Medical School was a wonderful experience. I loved it. Very broad spectrum of disease. I like the partnership between Elmhurst and the VA. And so when it came time to do a residency, I was pretty set early on for internal medicine. I knew that I wanted to train in a big city. I just felt that it would give me the most options. If I wanted to do a fellowship, it would show me the best variety of different pathologies. At the time, we had an HIV unit, a very prominent HIV clinic, oncology, GI. So in terms of the exposure, I thought it was amazing. I did like the combination, probably because I was a student here, of being at Elmhurst and having a lot of autonomy, and then having the whole educational backup piece at Sinai. So that was a big push for me. And so when I was applying, I was looking for programs that would give you kind of both. And when I was comparing, you know, our program at Sinai to some of the different city programs, you know, NYU had a similar layout in terms of their Bellevue exposure and the Manhattan VA versus ours with Elmhurst and the Bronx VA. There are some subtle differences between the programs, but I pretty much interviewed all around the city. So if anybody had any questions about the city, I did interview also at Stony Brook and a couple of places in Long Island. But again, I felt like the city exposure was really where the pathology was, and that's kind of where I wanted to stay.
Can you just rewind, if you can, back to when you were making your decision to go into internal medicine, and then why cardiology?
Oh, sure. So medicine I chose pretty quickly. I thought going into medical school that I was going to be a surgeon, and yeah, that didn't work out too well. I like the thinking nature of medicine. Larry Smith at the time was the program director and chair of medicine, and just the way they challenge you to think through different cases. And I remember saying like, oh, this is like a puzzle, and you have to put all the little different pieces together and figure out what's going on with the case. So I kind of like the idea of walking into the ER and you're having to be the diagnosis and figure out management, and kind of you get a little bit of variety of everything. And then as time went on, you know, you have to choose fellowship pretty early, and I was really torn because Mount Sinai has a lot of great fellowship programs to choose, but I kind of fell for cardiology because I think out of all the specialties in medicine, it allows you to actually, quote unquote, fix someone. So someone comes in with a heart attack, I can make you feel better. If someone comes in with, you know, chest pain, I can do my workup. Heart failure, I can get the fluid off. So it's very satisfying field.
And what's like a typical daily or weekly schedule for someone in your role?
For me now, I do mostly outpatient. I do office 3 days a week, and then I run the imaging lab. And so I get my exposure, as invasive as I get, is TEs and stress testing. So I get to do that. I stress 4 days out of the week, and I do TEs all through the week in between office patients. I do have a hospital-based practice. I'm not in private practice. So my office is actually based in part of the hospital. So it's very easy for me to walk back over and do my procedures and come back to office, as well as when my patients are hospitalized, it's literally a floor away. So I can go upstairs and round on them in the units.
And what made you switch from private to hospital practice? So you've really seen both worlds.
I did. The private, I must say, was very brief. And I thought, you know, at the time I was a young mom. I had 2 very small kids. And it was just really hard for me to balance the demands of private practice. My dream, as you know, from being at Sinai and then through residency, has always been academics and academic medicine. And then I just found as I got older and my kids started growing that was more important to me, the structure of academia. I didn't want to play a numbers game. I wanted to be able to come and teach and do a variety of different tests, and I really get to do kind of everything in cardiology that I wanted to do. Whereas in private practice, I was, in the office, and they do a fair amount of stress testing, but in terms of the higher quality imaging, TEEs and the intraoperative TEEs, the exciting things about cardiology are really in an academic center.
So I'm going to keep asking questions, but I see some students on here. So if any of you want to ask questions, feel free to just take yourself off mute. It's, pretty informal. And so the three of you that are on are all, one person said they're considering, and the other two, are you definitively applying to medicine or?
My plan is to apply into internal medicine. I actually do have a question for you, Dr. Stevens-Cohen. My question is, what are the benefits of, you kind of alluded to this, training in a big city like New York City? Is there great variance in the quality of training at maybe different institutions within the city, or perhaps even like kind of countrywide, regionally?
That's a great question. I think that to see the varieties, first of all, so training in the city and training at a place like Sinai, you're at a tertiary care center. So you're seeing a lot of, for cardiology, we saw a lot of, tetralogies and weird congenital things that you're not going to see at a smaller hospital. I hardly see, if at all, in my current hospital now. The same thing with GI and renal, all these different pathologies that people are referring from their smaller community hospitals into the city to get that more extensive workup, transplant evaluations, and things that we take for granted because we see them so often at Sinai are not really that common. And so that was a big key for me for staying in the city. I trained at the time when there was HIV was at its, all-time high, and to have a unit or a ward dedicated to HIV medicine, we take for granted. Now I'm at a place where I have residents that have never seen a case of HIV in the hospital. And so I really wanted that broad breadth of medicine. And then I think it's important as well, if you're considering fellowship, to stay fairly academic. I think it makes the rotations easier, it makes the exposure easier, and the application process more feasible. I really do.
Wow, they've never seen HIV on the floors before. That's crazy.
Right? We think of it, we had a whole unit. I rounded there for a month and a half, and then we had a patient with it wasn't even on their radar, and then they kind of tested it, and it was like, so now what? I don't really know what to do. And so me as the cardiologist, who's I wanted to say how many post years training that we are, but I had more of a clue, and so it's really interesting, and the things that we took for granted there, different types of liver disease, the cirrhotics, the doing LVPs that they just didn't know how to do. Because they weren't exposed to it. We were doing that as residents.
Wow. Jennifer, are you set on medicine?
Yeah, I think so. I'm planning to apply to research track programs in medicine. And I did have a question. I don't know if it, just only if you're comfortable talking about it, I guess. To be transparent, I have a daughter, I'm a mom, and I'm nervous about the idea of intern year with a family to take care of. And I was just wondering if you are comfortable talking about when you had kids, and if you had kids in residency or knew people who had kids in residency, what that's like.
Sure. It's another great question. I waited until my third year of residency to get pregnant with my son. And then my daughter came when I was a fellow, a first-year fellow. I did have two of my close friends were pregnant mid-intern year. And honestly, they were very, very scared because they thought that it maybe changed people's perspective on looking at them. Were they going to be taken seriously as internal medicine doctors? What if they wanted to go on for fellowships, and how about research? I never got that feeling at Sinai. It was pretty friendly. The biggest concern was obviously with the leave and how was I going to come in and could I make up for all the reading and the material acquired. But I had 2 friends during intern year, a couple of people second year, and it's definitely more common as you go up. I would say, listen, my always advice to even the current students now that rotate with me, life happens, enjoy it, do not postpone anything. Intern year is hard. It's going to be hard with or without kids. I think the kids actually make you a better manager of time because you have to kind of be focused and get yourself together. But I don't think it was an issue, especially at the bigger city programs. That question may vary at some of the smaller programs, not so much because you have a daughter, but in case you get pregnant again in terms of leave and coverage and who's going to take call. Some of those questions, Mount Sinai, it's a huge program. We were able to be out of the cycle and have our full maternity leaves, and nobody blinked an eye. There was no need for time makeup. You weren't putting any of your colleagues out. And so I have heard things like that, but that's usually at smaller programs where there may be 5 or 6 residents and you kind of need all hands on deck. Sinai is kind of built into the big city programs that have large intern classes. That's going to be less of an issue.
Thanks.
Okay.
And Samantha, you're considering medicine, or you're set on medicine also?
I'm considering it, and I'm interested in cardiology, which is what drew me to this chat. So thank you for sharing everything about kind of your career trajectory and why you made your choices, because hearing other people's thought processes are really helpful.
Good.
And so the cardiology was 4 years, right? Or
3
years, fellowship, 3. And so with the applications for that, did you have to do a lot of research during residency or anything like that? Because it's a very competitive fellowship.
It's pretty competitive. So Sinai actually has, well, now they have more than 2 tracks. So I'm kind of dating myself as well. But at the time they had 2 tracks. They had one research oriented track, which is really for the people that have real strong publications, bench research. Dr. Fuster was very big on that. And then a clinical track. And so I thought about it. I had actually met with Jonathan Halpern and Dr. Fuster to see if it would be worth taking a year off to doing research, getting published before I applied. And both of them decided or encouraged me not to. He said, cardiology fellowship is long enough. Now you got a young son at home, just continue and carry on your life and you can get into a good clinical program. So the track that I chose was Mount Sinai Elmhurst, where 8 to 9 months of the training is at Elmhurst and the other few months is at Sinai. And that was the clinical track program at the time, which still exists. It's under a different name, but Eric Stern and Jonathan Halpern run it. And there was no issue with me, again, being a city girl and wanting to stay in the city. I matched there and I was very happy with the training.
Wow, that's a really forward-thinking advice from them.
Yeah, surprising. So, a lot of times when you come in and you have I did not have extensive research background as an undergrad or a medical student. I was really focused on the clinical aspect. And so during residency, I did a few non-invasive papers with the Echo Lab and Lori Croft, who I still believe is there with nuclear, but it wasn't anything extensive. And so the advice that I got was there are good clinical programs in the city as they relate to cardiology, Beth Israel, a lot of programs in Long Island. And so I ended up applying to 6 or 7 and felt very, very comfortable and happy at Sinai.
And when you applied to residency, did you just do the Northeast or did you do everywhere?
I just did the Northeast.
I have may I ask another question?
Yeah, of course, go ahead.
Was there a decision point where you had to decide whether you wanted to be able to do inpatient and outpatient or predominantly outpatient, and what was that like?
For my current job? Mm-hmm. That is interesting. So that's another beauty about staying kind of in academics. I talk about it and that really depends on where you end up. So I know at, for example, Sinai, the non-invasive cardiologists kind of stick to imaging and then maybe do 1 or 2 floor rotations. The invasive guys are in the lab and it's kind of very already set. My current job is almost like a fellowship where I get to have my hands in just about anything. So I still do call, I round in the CCU. I run what they call like a short stay or observation unit for the chest pain patients. And then imaging, I kind of decided, just because it gives me the best flexibility in terms of being a mom. You know, every stage is different. So now my kids are a little bit older, but now they need me as their chauffeur to take them to every sports activity after work that I can possibly get to. So I needed something that was a little bit, you know, flexible. And so non-invasive imaging gives me a lot of flexibility, as well as office hours, because I get to set and say, hey guys, you know, I really need to be done by 2 because my son has a traveling basketball game at the end of Long Island. And in academics, that's okay. Right? In private practice, where, you know, sometimes it's a numbers game where people are watching your numbers, that may not be okay to end office because Dr. Cohen should have seen 10 more patients. But in a academic hospital-based setting, that's okay.
Do you take
things like
ER call?
I do.
Or
I do. I take ER call 1 day a week. I'm actually on call tonight, and I take one weekend a month.
and so how is that in terms of having to go in and emergencies and stuff?
And so again, it was very self-serving for non-invasive cardiology. For a woman, there's very, very few emergencies that I have to go in for. I basically have to go in for tamponade. The ACS cases, the STEMI cases are managed by the invasive guys. I get a call when they're done because I'm responsible for taking care of them afterwards and the next day on rounds. But for me, having to go into the hospital, very, very rare, maybe a handful of times a year.
Yeah, I think that's an important thing. It's like no matter what specialty you go into, a lot you can make it as busy as you want it to be, or you can definitely tailor it. So like same thing for like for orthopedics, I take trauma call, but again, I think I almost rarely go in because there's residents that are like the first line, and then there's always partners who may take those specialty cases. So I definitely wouldn't say not consider a specialty just because it seems like it might be. Because if I thought of cardiology, I would think like, oh my gosh, I have to come in, last minute or whatever for heart attacks and stuff. But there's all these other paths.
Completely agree with you. I think that, one of the best things, I think it was Dr. Murphy, who's still there, who said to me, it's not true that women can have everything, but you can have a lot of it. You have to just put the kind of pieces together and make it what you want. And it's something that they don't necessarily teach you. So if I had to look back and do it over again, I probably wouldn't have gone into private practice for those 9 months. That wouldn't have been a good option for someone like me. I'm glad I got the exposure so I can tell you about it, and also kind of taught me how to tailor my life to meet all of my needs for my family as well. And to keep you interested, we're in medicine, we love it. And we want to be challenged every day, and we want to be doing what we love. But there's a kind of place for everything, even something as invasive as cardiology, that you can kind of get a good balance.
So if you were giving, oh, sorry, go ahead.
Oh no, you can continue. I'll ask it.
No, go ahead.
Oh, I'm just kind of curious. It seems like there is a increasingly popular trend of doing a hospitalist year after internal medicine residency for various reasons. And I wonder what you think about that. Like, I don't know, the decision to do that, or why that might be.
It depends on where you want to practice. It became popular, I want to say, right when I was finishing, there was a thing called General Med Fellowship to kind of teach you how to be medical educators. And then there was this whole hospitalist movement, thinking that even though internal medicine, I don't particularly find, especially at Sinai, that there was an abundance of outpatient blocks, but that they thought that there was dedicated time to spend learning hospital-based medicine. I feel like internal medicine does that for you. That's the difference between us and some of the other family practices or primary care. So I'm not sure how beneficial a hospitalist year would be for an internal medicine graduate coming from a strong program. There are other programs where it's a little bit more balanced between the inpatient and outpatient. And for those programs that do about 6 months out of the year of outpatient, maybe it makes more sense. Coming from a program like Sinai, I'm not really sure what the benefit would be, other than to think if you wanted to run a hospital-based program, like be in charge of a hospitalist group in the hospital, that would be my only thought to that. In terms of fellowships or doing anything after the hospitalist-based year, I don't think that's necessary. So again, I think it depends on the program that you choose for internal medicine and what the ratio is and the exposure is to inpatient, outpatient, whether or not that's practical. I do have one or two friends that did that, but one was particularly interested and charged with developing a hospitalist program in their community hospital. So she did it with the intention of being the program director of that group.
So now that you've seen private practice, academia, kind of seen everything, if you were going to give your medical student self advice, is there anything along the way you would have done differently?
You know, I honestly don't think so. I think that everyone kind of comes to their path. I'm very happy with the decisions I made. I think that my goal from medical school on through residency and fellowship was to always stay in a city, in an academic environment, because I do feel like it gives you the most options. You know, I'm at a smaller hospital now, and the biggest concern is, well, who's going to notice me, or how am I going to get into a fellowship for those that are interested in, and it's a challenge for them. And I worry for them to think about how they're going to maneuver that coming from a smaller program. So I do think that staying large and staying academic helped me. And even though I ended up where I am at a smaller hospital, it's much easier to go from an academic institution into private practice or into a smaller community hospital than it is to go the other way around. I rarely see the jump from someone coming from a small community hospital ending up in a big academic center.
How did you make the jump from private practice to back to academics?
So it's interesting, when I was in private practice, this was one of the hospitals that I used to admit patients to. And they had a vacancy in their echo lab, their imaging lab, and it had been something that I was really, really interested in. So I applied, and that's kind of how I got back in the door.
Yeah, you're right, because it definitely is hard to do it the other way.
Yes.
Okay, great. Emmy and Jennifer, any other questions or?
I have another question, which is, were you ever dissuaded into applying into cardiology because of the competitiveness? Or like, I've also heard that GI is very competitive.
Yes.
Yeah.
I was. And so I would say that for the clinical programs, I was encouraged by Dr. Halpern and Dr. Stern, but for some of the more academic-based programs, the research-based programs, I was told that it was very, very competitive, that I probably would have to broaden my application because I was so resigned to being in the city. And at this point, I was married and had my first son. So I wasn't able to pick up and move. And so I applied very, very broadly all through Long Island. And there's different, you know, the A and the B and the B plus tiers. And that kind of all goes out of the window when you're coming down to a fellowship. And so I knew that the research-based bench research, Mount Sinai, Maine, Cornell, Columbia, some of those bigger programs, where we used to laugh and say you have to basically be an MD, PhD to get in. I knew those were off the table for me. I needed somewhere where I could be a good clinical cardiologist. And luckily at the time, Sinai was developing this urban community program out of Elmhurst, which is very similar to NYU's program, where they do the majority of their cardiology rotations at Bellevue. And then they also flip back to NYU. So it's a very similar outlook, those two programs. And so I felt that that was the best option for me. And in terms of my safety, if there is such a thing as a safety school for cardiology, I did a lot of the programs on Long Island, thinking that sometimes, you know, we're lucky because we're in the city, but just going a little bit out to Long Island, Queens, even Brooklyn, like some of those neighbors are less competitive because everyone wants to be in the city. So that was my kind of backup to apply to some of those smaller programs in Long Island.
I definitely think the city hospital is key because I did my residency at NYU. And we rotated at Bellevue. And it's like, you know, you'll see people who basically fly from Bangladesh and get off the plane at JFK and come to the hospital just to see a doctor. And you're right, you'll see stuff that, I mean, you guys know because you rotated at Elmhurst, but you'll see stuff you'll never see anywhere else. And that's what you want to see during training. You know, there's no way to predict what you're going to see in practice, but if you can see everything you can possibly see as a resident or fellow, it can only benefit you later.
And that was my goal. Elmhurst cardiology is amazing because there's a lot of Central America and a lot of Southeast Asian. We saw so much rheumatic heart disease, congenital disease that you would never see if you were in a different population. They all get corrected as kids. So we never see them. I was seeing them when they were pregnant, presenting for the first time. So it's a very, very interesting pathology that I probably would not be able to duplicate anywhere else.
You saw the mothers who had the babies that had the pathology. Wow.
Yeah, we had someone with a tetralogy, never knew, undiagnosed tetralogy. The extra burden of the baby caused her to have some flow reversal. And so she started getting short of breath. And that's how we figured her all out, able to get her through the pregnancy. She was corrected afterwards. Luckily for her, her shunt wasn't that bad to cause pulmonary hypertension. So she was able to be corrected, but you would never see that.
Yeah, and you'll never forget,
and
you'll never forget that case either.
No,
wow,
exactly. So they're really, really interesting stuff at Elmhurst. Love it.
All right, great. Emmy and Jennifer, any other questions that you have?
This was helpful. Thank you.
Good. I'm glad.
Thank you so much. I guess I have one last question. I've been like hogging questions. Is there one thing that you would say is preventative for clinician burnout that you've noticed?
Huh.
Or
That's
like
a tough
one
one.
thing among maybe many.
Have you ever felt burnt out?
Absolutely. I think the older I get, I look back, and when I left, I was at Sinai Elmhurst system for a little while, even as an attending. And when I made the jump over here, I remember laughing as I checked out because I had like 6 or 7 months of sick time and a bunch of unused vacation that I never did. I think, and I was just talking to my husband about this the other day, if I could go back, the one thing I would probably change is take your vacation and take your downtime. And I think that we spend so much time trying to be the best physicians ever. And I remember one time checking out of IMA primary care over at Sinai, and it was like maybe a Friday at 5 or 6 o'clock, and a patient had run out of medication. And they called the office frantic, like 7 or 8 phone calls, and they called all weekend. And then Monday came around, and my attending was like, you know, I'm not going to jump in front of that bus, Pilar. And I was like, what do you mean? And he was like, patients have to take responsibility for their own healthcare. He knew he was running out of medications. I can't run around like a dog after calls. It was before the age of EMR where you could just pop it in and do this paperwork and do that. You can be a slave to your patients because everyone's going to always need something for you. And so you have to know when you can shut off your phone, shut the phone down. I'm not answering any messages. I'll deal with it on Monday, and take the time for yourself. And so now I'm much more, in the past 3 years, I take my vacation time. Sick time, I'm not that great at. It's very hard for a doctor to call out sick, I must admit. But I take all my vacation and I make sure I spend time with the kids.
It's so funny that one of the secretaries in our office has a sign that says, "Your lack of planning doesn't constitute an emergency on my part," which is kind of that's true though. Yeah.
Said. I thought he was going to yell at me and say, "Oh, you should have given the medicine, or we could have done this." And he was like, "No, it was 5:30. You knew you were down to your last pill. Why are you I'm not going to ruin my weekend." And it was just so funny. It was not what I was expecting. But he was right. And so I've kind of tried to adapt that attitude where, your emergencies are the things that get you all worked up. I can't run and jump and get all worked up all the time. You just get so tired. And it's really hard as a parent and as a wife and as a friend, all the things that you want to be the best at everything. And, we're type A by nature. We want to be the best at everything. You guys are Mount Sinai medical students. You're top tier. This is how we got to this point, by being competitive and giving it our all the time. And I think that it can lead to burnout. So most importantly, because residency is very, very hard. And I know we do a lot of things now that we didn't have when I was a resident in terms of, socialization and yoga and meditation. Take your vacation. It's okay to say when. I've had enough. And you don't have to be everyone's savior.
Yeah, that's definitely true, because especially with email, you can get patients contacting you at all hours of the day. And so if you don't put those boundaries up,
exactly,
then they're going to think it's fine. Yeah.
And I've had people say, "Oh, Dr. Cohen, I emailed you," because my email address is on my card. "I emailed you and I'm not on call that weekend. I'm sorry. You could have called the office."
Yeah.
And you have to be able to say it, and it's okay. And they may not like it, but it's okay.
Yeah. That's a great point. Okay. Anything else, guys? don't feel like you're hogging the questions. This is like,
No,
you
it's
know,
great. I actually
you're here,
love
yeah.
it.
All right,
It's,
good.
listen, for a woman in
So,
medicine, it's challenging. It's
yeah.
definitely challenging, and every step will be challenging. And like I said, I just finished a whole shebang of recertification, so that means I'm like 10 years plus out. And I'm constantly trying to reschedule and revamp things to make more room, because the demands constantly change. And I think that's the key, to keep doing those internal checks and making sure that all of your needs are being met, and making sure that you're okay. Is my lifestyle okay? Am I happy with this? Is it okay that I don't know exactly what I'm doing? Someone asked about the private practice thing. Everything at that point had been a match. So this was my first like big girl job interview. And I think, 70 to 80% of us change after our first job within the first year or two, is a testament that maybe we're not really kind of sure all of what we need until you get in it. But that's okay to also make that change and say, you know what, private practice wasn't for me. I'm very happy in academics.
Yeah, definitely. I think the other thing I was thinking too was like patient appointments. I don't know if you've ever had this issue, but the patient's scheduled for a certain time, and then I used to feel so bad, like, oh, I don't want to, if they came in 30 minutes late, I would say, well, I'll still see them and this kind of stuff. And then you realize that it eats into your time. That's time that you could
Absolutely.
be spending with your family, doing research or whatever. So you have to put those barriers up. And I think definitely taking the vacation too, because we're so used to being like, go, 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 and being monitored and that kind of stuff. And I think probably one of the best things I ever did was in the summer for like 6 weeks, I'll take my summer Friday and not see patients on Fridays. And
Yes.
having like a 3-day weekend is such a mental break
I
to
love
have.
summer Fridays. I actually do that as well. I'll go in and read, but like tomorrow
Right.
I'm off. I'm not doing anything. Leave me alone. Summer Fridays are key.
Yeah. So yeah, definitely making sure that you take time for yourself is really, really important. Okay, great. So this is going to be I guess it's videoed. So, Pilar, you can watch it in another 10 years and see if you would give yourself the same. Thank you so much for taking the time to do this.
I appreciate it. Thanks
really
so much
valuable.
for reaching out to me. Best of luck to everyone. And please email me with any specific questions about cardiology, family life, women in medicine. I'll be more than happy to chew your ear off a little bit more.
Yeah, definitely. Pilar, I would say, is like, I basically never saw her without a smile for like all 4 years in medical school. So I think like, she has a good outlook in terms of advice and stuff. So we'll put her in the alumni database.
All right. Thank you so much, guys.
All right. Thanks, guys.
Bye-bye.
Bye.